insufficiency, how to differentiate between the two types, the causes and the signs and symptoms. Today here we are going to discuss about the management of acute adrenocortical insufficiency. Acute adrenocortical insufficiency results from damage to the adrenal glands or dysfunction of the hypothalamic pituitary adrenal axis. It is precipitated by factors such as trauma, infection, stress, both physical and emotional stress, and abruptly stopping the glucocorticoid therapy which is meant for long-term use. So this can precipitate an adrenal crisis which is a medical emergency. It is a medical emergency because the onset is sudden and severe and requires aggressive and immediate treatment to stabilize the patient and prevent death. The signs and symptoms of adrenocortical insufficiency is due to deficiency in aldosterone and deficiency in cortisol production by the adrenal glands. Firstly, adrenal crisis results in severe hypotension and shock. There can be life-threatening fall in the blood pressure, and this is because of aldosterone deficiency causing loss of fluid and decreasing the blood volume, resulting in hypovolemia, hypotension, and the patient can go into a shock state. Secondly, aldosterone deficiency causes severe dehydration, and this is due to rapid loss of sodium and water from the body, causing dehydration. Thirdly, electrolyte imbalances can occur causing hyponatremia and hyperkalemia. Hyperkalemia can trigger electrical activity of the heart giving rise to arrhythmias, and hyponatremia can cause CNS manifestations such as confusion and disorientation. So severe electrolyte imbalances occur, and this is also because of aldosterone deficiency. So aldosterone deficiency causes severe hypotension, shock, severe dehydration and electrolyte imbalances. In addition to aldosterone deficiency, there can also be cortisol deficiency, and cortisol deficiency causes severe hypoglycemia because deficient cortisol impairs gluconeogenesis, and because of reduced gluconeogenesis, the blood glucose levels fall. So there can be dangerously low blood sugar levels, and this is because of impaired gluconeogenesis resulting from deficiency in cortisol. Also, GI manifestations can result from deficiency in cortisol because cortisol is important for maintaining normal GI motility. So, deficiency of cortisol can increase the GI motility, causing severe abdominal pain and diarrhea. It is often accompanied by nausea and vomiting. CNS manifestations such as confusion and coma results from hypoglycemia and hyponatremia. So to sum up, aldosterone deficiency causes severe hypotension, shock, severe dehydration and severe electrolyte imbalances, whereas cortisol deficiency causes severe hypoglycemia, CNS manifestations such as confusion and coma, and GI manifestations such as abdominal pain, nausea and vomiting. So now that you are familiar with the clinical presentation of acute adrenocortical insufficiency, let's now discuss the management of acute adrenocortical insufficiency. As we know that it is a medical emergency and requires immediate and aggressive treatment. Therefore, immediate administration of corticosteroid is essential. High dose hydrocortisone intravenously 100 mg bolus followed by 50 to 100 mg 6 to 8 hourly is administered. So now the question arises, why is hydrocortisone chosen instead of other glucocorticoids such as dexamethasone, betamethasone, paramethasone? Now hydrocortisone is the preferred choice in acute adrenocortical insufficiency because of several reasons. So firstly, hydrocortisone has a rapid onset of action. It quickly raises the blood cortisol levels and provides immediate relief of symptoms. Secondly, it has a short duration of action. The half-life is about 8 to 12 hours, and this allows flexible dosing and adjustments based on clinical response. Thirdly, hydrocortisone is identical to natural cortisol that is produced by the adrenal glands, and therefore it mimics the physiological actions of cortisol, including the metabolic effects and the anti-inflammatory effects. Importantly, hydrocortisone has mineralocorticoid action which is deficient in acute adrenocortical insufficiency. So through mineralocorticoid action, it restores the blood volume, maintains the blood volume, the blood pressure, corrects the electrolyte imbalances, and therefore hydrocortisone, because of its mineralocorticoid action, is preferred in adrenocortical insufficiency. Lastly, hydrocortisone is available as intramuscular and intravenous formulations, and this makes it suitable for rapid administration in emergency situations. In contrast, other glucocorticoids such as dexamethasone have a long duration of action, and also they lack mineralocorticoid activity, unlike hydrocortisone, which has the highest mineralocorticoid activity in addition to glucocorticoid activity. And therefore, hydrocortisone is the preferred choice in acute adrenocortical insufficiency. In addition to administration of corticosteroids, aggressive fluid resuscitation with IV fluids is essential, and this is done using isotonic saline or dextrose saline. So this helps in raising the blood glucose levels and restoring the blood volume in adrenal crisis. Apart from this, supportive care such as continuous monitoring of vital signs and monitoring and managing electrolyte levels, the blood glucose levels is essential. Lastly, addressing the precipitating factors such as infection, trauma and other triggers should be addressed to manage adrenal crisis. So this was about the management of acute adrenocortical insufficiency. Chronic adrenocortical insufficiency is a long-term, gradually developing condition that results in hormone deficiency. So this requires long-term hormone replacement therapy such as fludrocortisone and hydrocortisone. So with this we come to the end of the topic. Thank you so much for watching. If you find my video useful, please like and subscribe to this channel.